Fantastic. Welcome everybody to this evening's article review webinar. On the panel this evening, we have Carl Horton, who has an MSc in both implantology and perio, is an implant co-director, course leader and mentor for VSS, and is an honorary lecturer for UCLan. We had Fadi Barak, who is an academic lead with a master's in dental implantology with UCLan. He is duly qualified in medicine and dentistry and has vast experience in oral and maxillofacial surgery in hospital and primary care. He also heads up the VSS Academy. We have Manoj Bhattiri. Manoj holds an MSc in implant dentistry, is a senior clinical teacher in implantology and a clinical supervisor and examiner at the University of Central Lancaster. We have Professor Sinjan Kreen. He is the current Dean of the School of Medicine and Dentistry. He is also a consultant oral and maxillofacial surgeon at Blackpool Victoria Hospitals Trust and holds an honorary consultant post at Lancaster and Morecambe Bay University Hospitals Trust. I will now pass you over to the capable hands of Fadi Barak.
Thank you, Kate. Welcome, everybody. This is our first Dental Bites meeting where we're going to be looking at some review articles. Just a very, very brief word on what this is about. So the idea is to make reading articles and keeping up with the research fun, as fun as we can make it. And in essence, we're going to be looking at a certain number of articles from some well-known journals and just picking up interesting bits from them. This is by no means an exclusive search of the journals. It's just the 4 or 5 top journals that we usually look at and picking up specific papers of interest that have impact on what we do clinically. So the other thing is it's not going to be kind of a complete, deep, critical analysis of the articles. That's not the aim. The aim is just to make you aware what papers are out there, and hopefully you'll be able to go out and read them in more detail yourself if it tickles your fancy. So here we go. I'm going to start with a subject of socket shielding, and the reason is because lots of colleagues have been talking about socket shielding, asking me about socket shielding with regards to implantology and how successful and so on. Can I just say there's lots of background noise? Is it possible if maybe we can put some microphones on mute to see? I don't know if it's just me, but I can hear some. Okay, that's better. Great. So with the socket shielding, there was an article. I will try and share my screen. I'm sharing my screen with a journal that's, let's have a look. It's open access anyway, so anybody has got access to this. International Journal of Implant Dentistry. So socket shielding technique is a critical literature review. This literature review looked at 25 articles, 20 of which were actually case reports, just case reports. There were 3 retrospective studies, 1 randomized control trial, and 1 control trial. Now, this in itself reflects the level of the articles that there are there in terms of the level of evidence for socket shielding. This was from 2020. The case reports, the 20 that we look at case reports that had very different kind of outcome measures. So what I mean by that is some of them looked at the pink aesthetic score. Some of them looked at positive results. So very general kind of information. So the result was good. We had good results. And there was no specific quantitative measure of why was the result good. And some looked at volumetric dimensions, either 2-dimensional or 3-dimensional volume maintenance. Of the basically the one RCT, which would normally be a better evidence, there were 20 papers that looked, there were 20, they looked at 40 implants, 20 were test groups and 20 were control groups, and they reviewed them over a 3-year period. So the numbers were low, and the retrospective studies had very, very inconsistent designs. But nevertheless, it's the review, has tried the best in terms of the evidence that's present for this particular type of surgery. Now, the outcome measures were inconsistent, but one of the interesting things was they looked at complications. The complications they reported were included things like exposure of the shield, of the bit of dentine that's left in the socket, and that was the highest rate of complication, was those bits of dentine becoming exposed. 17 were exposed and 2 got infected. Then there was the next complication was actually resorption of these bits of dentine. Another couple of complications were peri-implantitis, and there were actually 7 implant failures as well. So there were quite a few complications. There were different techniques used, and the conclusion from this paper really was basically that there isn't enough evidence at this stage to use this technique as a day-to-day basis for implant work. Interestingly enough, another paper, which was also recent, from the International Journal of Periodontics and Restorative Dentistry, and this was done by Otto Zur and Philip Stahler and Marcus Hörsler. Marcus Hörsler, as you may well know, was the person who came up with this very clever technique of socket shielding. And the idea behind the socket shielding, the way he came up with it, was that by keeping a bit of the dentine from the root in the socket at the buccal aspect, you will preserve the ligament attachment to the buccal plate, and hence you will preserve the bundle bone. That was when we realized that if you take all the tooth out, the bundle bone will resorb anyway. So Hörsler has done various studies on this, and this recent paper was looking at complication management of a case, 6 years in function. And this was very interesting because they looked at this particular case where the dentine became exposed, but they noticed that the adjacent tooth had over-erupted as well, had come down further in the apicocoronal dimension. And the theory is that what's happened with vertical dimension growth, which can happen beyond 20s, and actually there are studies to show that it carries on throughout life in some cases. Because there's this increase in vertical dimension, the bit of dentine that they've left in the socket can actually also grow vertically, whereas the implant stays behind. So what they believed happened in this particular case is that that bit of dentine moved down vertically with the rest of the alveolar bone and teeth, and that bit of dentine started hitting the restorative component, the crown of the tooth, and started causing problems, and it became mobile. That was quite interesting one to show that that's a possibility. And the way around that was to make sure that actually the bit of dentine needs to ankylose. It needs to be in contact with the implants or be long enough for it to ankylose with the implant so it doesn't move in case of vertical dimension growth. I think the importance of this for us is even in Hörsler's paper, Otto and Hörsler, they say that really more research is needed. Okay, I think for me that was the interesting thing with these 2 papers on socket shielding, that it's a clever idea, biologically fantastic, and this is what makes surgery interesting and exciting, but this is not for mainstream use yet. And even in their own paper they say that it should not necessarily be used on routine implant dentistry yet. More research is needed, and also to consider that when things do go wrong, i.e. You get an exposure or loosening or infection of that bit of dentine, it needs to be removed. It may not affect implant survival, but it may well affect aesthetics. which is the whole point of doing that procedure anyway. So the implant survival, with all the complications, was not really affected, but the actual aesthetics was in certain cases. So that's socket shielding. I'm going to move on to another paper, which was to do with the use of low-dose aspirin on, let me show you the paper again. We will be sending you a list of these papers, so you don't have to memorize it. So effects of low-dose aspirin on the osseointegration process in rats. Now, this was an animal study, fair enough, but the idea behind this study was that, look, non-steroidal anti-inflammatories have been discussed in terms of their relationship with bone metabolism. Some people say that they can affect bone metabolism negatively, others say otherwise. So there is a bit of controversial data on this. This particular study looked at 32 rats, and they divided these rats in 4 groups randomly. There was a control group and a test group. In the control group, they had a group of rats that were given saline for just 7 days, so short term, and another group of saline that were given saline for 28 days, so that's the long-term use. The test group had aspirin low dose, so the low dose was equivalent to the human 70 to 80 milligrams that we do in the humans. The equivalent dose in rats was given. So they used that for 7 days, short-term aspirin use, and 28 days long-term. What they found was that obviously in the control group, 7 days and 28 days, there was no difference, which is what you would expect. I'll show you the chart briefly. So here's the use of aspirin. So this is 7 days, it's 28 days. And what they looked at histologically, they looked at the bone implant contact, percentage of bone implant contact. The white bar is the control, so 7 days, 28 days, no difference. What they found at 7 days, there was a significant reduction in bone to implant contact, which recovered at 28 days. Okay, so early bone to implant contact was reduced at 7 days. The other thing they looked at histologically was the bone area between threads, which showed the same thing. So in essence, what this paper showed was that the low-dose aspirin can affect early bone deposition around the implant, but that can recover. So what's the significance of that for us? I guess we need to consider early loading or immediate loading. In patients who are on low-dose aspirin, chronic low-dose aspirin, then, could that be an issue when we're doing immediate loading if there is an early reduction in bone deposition?
5 minutes, Fadi.
Okay, thank you. So the very briefly, the limits of the study, as the authors themselves said, that they looked at only implants with machine surface, and they didn't look at the roughened ones. The other thing we could consider is higher dose non-steroidals over long term. Some people are on those. Last paper I'll go through, which is interesting also. It's with risk markers for cardiovascular disease. This one compared the effects of cardiovascular disease markers with that of peri-implant disease. What they looked at, so they had a series of patients with peri-implantitis. So 58 patients had peri-implantitis, 49 with peri-implant mucositis, and another 49 were healthy implants. They did blood tests on all of them, and they basically, having looked at all the variables, the main factors that they found to be significant were that the vitamin D levels were lowest in the patients with peri-implantitis. The next lowest level of vitamin D was patients with peri-implant mucositis, and as you would expect, the next level was the healthy patients. So they had the best vitamin D levels. The other interesting thing was levels of uric acid and triglycerides. They found there was a positive correlation between high uric acid and triglycerides and peri-implant disease. The outcome measures were like bleeding on probing, pocket depth, and so on. So that kind of brings in the question of why that is. Uric acid may have a relationship with increasing inflammation, increasing the inflammatory factors, and so on. And there is a correlation between cardiovascular disease and high uric acid. We know there's a relationship between cardiovascular disease and periodontitis. Is there, the question is, a relationship between periimplantitis and cardiovascular disease? So that's quite interesting, I thought, and there are more studies needed. It's a difficult one to do. This particular study, for instance, they didn't look at X-rays. They had low numbers, as they said themselves. And what the other thing they could have done to look at inflammatory factors in the sulcular fluid. So more experiments needed, but it makes us think, low aspirin patients, cardiovascular disease relation, and should they be doing blood tests for uric acid levels with patients with known history of cardiovascular disease? I think I shall leave it at that, and I will be sending the list of papers.
That's smashing. Thank you very much, Fadi. Over to you, Carl.
Hey, fantastic. You missed out St. John's being a part-time comedian as one of his other roles. He's not going to go off mic and heckle me now. So I've got quite a few papers that we're going to go through. I'm looking at the International Journal of Oromaxillofacial Implants, and I think volume 5, I think, possibly 6. I'll have to check on that. And I've selected sort of 4 papers that were of interest. I found quite a few articles that were quite interesting, but we've got limited time, so I've got to keep things down to a minimum. So the first paper that I'm going to be chatting about is titled "The Survival Rates of 8mm or Shorter Tissue Level Implants in Function for Up to 228 Months." So this was, it's a study by Paul Fagazotto, who's an American, and he's done a retrospective study examining the success rates of shorter tissue level implants, so specifically tissue level implants, which is of interest really. And the reason that we're kind of interested in whether or not shorter implants work or comparatively successful to their longer alternatives are really so that we can have a look at areas that patients may be able to have an implant placed where originally we might have either avoided it or augmented it, or sinus lifts, so increasing the morbidity. So that's the reason that we're kind of interested in looking at short implants. Obviously, over time, the definition has changed, and we've talked about this previously, where definition of a short implant was 10mm, then 8mm, and 6mm. But for this particular study, he's looked at mainly 8mm implants, but he's also included different implants, 6mm and some 7mm implants. And what he's done is he's sort of had a look at the different tissue level systems. So he's had a look at the regular neck and the wide neck. So these are specifically based on Straumann implants. He's included 4,251 implants that he's had a look at on single unit crowns. So it's very specific in the area that they're looking at. So there's no splinted restorations there at all. So it's specifically single unit crowns, and sort of focused really on having a look at those. The methods were which were quite laid out, quite interesting, where they've deselected certain papers. They've included the study from 1998 to 2012. And then the results that came back were looking at the success rates and the cumulative, I can't even say the word, but success rates over time. And when they looked at, or when he looked at these, they were getting very good values, which, you know, we probably feel is looking at about 99% plus. So these are comparative with the longer implants. The one thing that I wasn't able to pull out of the data, which I would have been interested in, and it may be that I've scanned things a little bit too briefly, so it might be worth looking at it in a bit more detail, are the comparisons between the 6 and the 7 millimeter implants in their success rates. I couldn't pull that out from the paper, from the tables that I was looking at, and it may be that just wasn't included. I would imagine that it's going to be slightly less. What the paper then does go on to is it goes on to discussions of other papers. So there are lots of papers out there that do talk about sort of 8 millimeter implants, and lots of research. There's some good systematic reviews, Nissan being quite a good paper to have a little look at if you're interested in this. The data on the shorter implants, Esposito and his group have had a good look at that. So when it comes to the 6 millimeters and below, but I thought it was a nice paper that kind of sort of supported some of the evidence without there, and the conclusions that came from this, that the regular neck and the wide neck implants from 6 to 8 millimeters long demonstrated a high level of success, which I think is supported by the literature. So I thought it was quite a nice little paper to have a little look at and have a little read, and makes you feel good. The next paper that I had a look at is a question that was raised by a few of the students that we were lecturing, and one that I get asked about, and that's the difference between fully guided versus what they've termed as half guided and freehand implant placement. And this was a systematic review and a meta-analysis, and I'll try and share my screen so you can see the paper. Just bear with me a little bit. So this was quite a detailed study in terms of how they went about this one. So let's have a little look and see if I can select that for you. If not, you'll just have to, no, I can't, I'm afraid. So you just have to have a little look at the study. But this was quite interesting. And I think this is interesting because some of the questions we get asked with some of the students that are coming in, and by my colleagues who are a bit more experienced, are whether they should go fully guided or whether they should just go with what we term an open stent, or what they term in this study as sort of half guided. And what they did in this study is they decided that fully guided was pretty much everything, from the fact that it's planned on the computer all the way up to the whole of the implant is placed with the guide. And then if somebody chose to place the implant without the guide, then that was classed as half guided, or if they used an open stent, that was also classed as half guided. So they lumped anything with a stent, or anything where somebody's done something slightly off guided but has a guided approach in there, as half guided, and then freehand. They do mention about the dynamic navigation of the 3D software, which is something we should probably talk about at some other point. It might be nice to see some research on that. But that's where what happens there is, as you're placing the implant, there is actually another screen that looks at the CBCT screen and tells you where you are within bone. So that's the dynamic navigation. And they're not talking about that in this. They're talking about having a stent and fully guiding the implant all the way through. And the reasons that they're looking for this is that they're looking to get the implant in the ideal position to avoid any issues. They do go into quite a lot of detail in what they could have looked at. So it's very detailed. They talk about flapless, they talk about timings, they talk about whether or not they could have measured any drugs that were involved. They do look at some secondary objectives, so it is very, very detailed in that. The eligibility is randomized controlled trials, so they've had a look at those. So it's all on humans, and they looked at papers where there were comparative approaches. So they wanted to see two approaches, one against another, within the same paper. So they didn't just select papers where one modality has been performed, but they actually look at the comparisons between the two, which I thought was quite good. So they did outline that really well. Their study selection, as I mentioned, came down to 10 randomized control trials. So they didn't have sort of a huge amount to work from, a huge amount of papers, and they recognize that. But within those papers, they do manage to look at a total of 1,200 implants or above that. So they do manage to have a good look at a lot of implants. They outline it really well. They have a look at the deviations coronally. So they look at that aspect of it. They look at the deviations apically, and they look at the vertical deviations as well across the studies. And they contrast and compare those. I know I should say obviously, but I shouldn't use the word obviously. But when they compare the freehand approach with the half-guided technique, they found that with the half-guided technique, there was a lot more accuracy, certainly when it came to vertical placement, which they found, oddly enough, was still there when you went for the fully guided approach, but sometimes there were some issues with the vertical placement on the fully guided approach. And what they thought this might be due to is the positioning of reliability on where the guide sits as it's being designed. So that was quite an interesting thing that came out of it. But their conclusions really found that the fully guided and the half guided approach were far superior to freehand, which again, I think, as the first paper kind of backs up what our thoughts are and what the evidence is really showing us. And then I'll move on to another paper now. Fadi, are you holding tight, because this one is on implant surface. So I don't want you to get too excited about this though. So the title of this one is The Influence of Implant Surface on Maintenance and Marginal Bone Levels for the 3 premium implant brands. And it's a systematic review and a meta-analysis. And this was by Michael Norton and Mikhail Astron. And they sort of chose 3 brands that they felt as premium. And they wanted to have a look at the premium brands because in their opinion, as they state in the paper, that some of the less premium brands can have problems with what's on the surface already. So they wanted what they call a clean implant surface, I suppose. They didn't call it that, but that's what they're looking for in the literature. So they want an implant surface that has no contaminants on it, or as little contaminants as possible. So they felt that they wanted to choose these 3 to have a look at. When they talked about it, they said they could find very little evidence previously about the modifications on implants and marginal bone maintenance, except one paper that they found. They looked at they talked a little bit about platform switching has been measured, and the submerged and transmucosal approach has been measured, and the implant abutment connection has been measured, but not this aspect of the implant surface and the maintenance of the soft tissue, which we're now really interested in when it comes to implants. We're looking at how these sort of soft tissues respond. So that's why they wanted to have a look at these marginal bone levels. So the 3 implant systems they looked at were the OsseoSpeed, which is the Astra, the SLA and the SLA Active, which is Straumann, and the TiUnite, which is the Noble systems.
5 minutes.
Oh, really? That's gone quick.
I know.
Crikey. Well, they got lots. I'll speed up. Crikey, I'm going to run out of time. So they got 2 time frames. They looked at the 1 year and the 5 year, and then they did some analysis of the SLA and the SLA Active and the different surfaces. And when they did that, if they found that there was no deviations between the 2 surfaces, then they basically clumped them together, and they looked at the marginal bone loss, and then compared those with all 3 against each other. They looked at immediate protocols as well for 1 and 5 years. So they basically ended up with sort of 4 tables, and then compared the standard deviations where it was appropriate. And then when they looked at it in sort of great detail and pulled everything, they found there was a slight difference between the implant surfaces, with the Straumann implant sort of being fairly medium in the group, and with the OsseoSpeed being slightly better in its performance over the 5 years and over the 1 year, actually immediate loaded or not, with the TiUnite sort of performing a little bit less successful when it wasn't immediately loaded, certainly after 5 years. But we're talking millimeters here, so they're seeing a difference of millimeters. So it's a good little paper, and I think Fadi, I can understand why you might get excited, because implant surface technology, we're looking at that in great detail, and we're looking how that affects. They don't go into a huge amount of detail on this regarding the technology, and I think we could open that up, and I think as papers come through, we're going to see a lot more of that and a lot more. But I thought it was a nice paper to kind of get us started and get the interest going on how that technology can affect it. So I'll finish off, if I still have time, if that's okay, Kate, with which I thought was a nice little paper where the guys have got together and they're talking about the development of an artificial intelligence model to identify a dental implant from a radiograph. Nice and succinct title. And they talk about a convoluted neural network, or a CNN. And what they've done with this is they've taken radiographs. I think you had to have 100 radiographs for the systems that they were having a look at, and they chose 6 systems to look at. So I think there was Straumann again in there, Swiss Plus, Nobel were in there, but I think there were Brannemark, and they talk about this app called What Implant Is This, which I use sometimes when I'm trying to identify a system, and that they mention its use, and they mention how sometimes that implant sort of data or identifying an implant can be quite difficult, especially if the patient loses what they've gone, or I've certainly had it where a patient's either had the implants placed abroad, or they've come from a different clinic and the implantologist has left and the notes have also mysteriously disappeared. So when you're trying to identify this implant, they all have different connections. So what they've tried to do is they've tried to build this really interesting computer model to identify the implant from a picture. So they take the radiographs, they turn it into a picture, then they put the picture into the computer model, and then through the way this computer brain works is it sieves through a various load of filters down to give you the identify the implant for you, and then pops out, it thinks it's this, basically. And they got really good success with it. They did really well with it. They got, I think it was around about 97 to 98% success in being able to identify the different implant pictures that it was given. And the more data that this sort of network gets, then the more accurate you're going to get a reading. And that's kind of how the What Implant database currently works, but it relies on going through this filter. And when I first was looking for identifying implants, I found some of the terms a little bit confusing. I didn't really understand what they meant. And it would have been really nice if I could have had a picture and put that picture forward. What happens now is that picture comes to me via WhatsApp or as an email, with the people that I work with going, any idea what this is, mate? And then I go to What Implant Is This if my brain doesn't recognize it straight away. So I think having a system like this that can help us identify what implants we're placing in patients when that data's gone missing would be really helpful for us. And it will take away some of that error that we sometimes have to go through in trying to figure it out, or asking all those people, or all the delays that can happen. It is already in place in some aspects of medicine to some extent. So the orthopedic surgeons are already using something similar to this. So they're kind of building on that model. But I thought it was wonderful. I like this kind of this stuff. But I think, Kate, I'm probably getting to the end of my time, so I shall wrap it up there.
Thank you, Carl.
Thank you very much.
Thank you. Over to you, Sinjin.
Thank you very much. Thank you, Carl. Brilliant. Some very interesting papers. Colleagues, so I had the same problem Carl had with my current technology and trying to get the papers up to you. You'll get the list of the papers sent to you. Even happy to send the PDF. They're a bit big, I guess. I was asked to look at what's called the Journal of Dental Research, not an implant journal, but probably one of the top research journals that dentistry owns, particularly for the UK and out towards America, and then beyond the west coast of America. So it's a very strong journal, reasonably high impact factor, and quite hard to get papers landed in it because they're pretty severe when they scrutinize the types of papers they accept. For those of you who've met me in the past will know that I've got a bit of an interest in medical challenges and trying to rationalize what that means to us in clinical practice, whether we do or don't go ahead with various treatments. And also, many of you might know that I'm quite interested in legal issues and the emergence of the Montgomery ruling when it comes to consent. Montgomery versus Lanarkshire in 2015 pretty much insists that we have discussions with patients that will take into account all the material risks that the procedure brings, and that of course has got to take into account the likely survival rates or issues that might interfere with that. So I've gone looking in the Journal of Dental Research for papers that are of relevance in that arena, particularly highlighting conditions that you may or may not have thought of previously to bring to your patient's attention could be a risk factor in predicting the successful outcome of the treatment they're about to undergo, which, according to the Montgomery ruling and subsequent rulings, means we really have to be able to give them that information. So when you do read the papers, I hope you'll see the big messages that are coming out. So I've got 3 or 4 here, 3 of them all to do with implants, 2 of them very contemporary, 1 of them a little bit aged, and then another paper which I picked up, which I think was currently quite pertinent. So the first paper I want to highlight to colleagues is the paper which is a research report. So it is a research paper. It's written by Y.N. Wang and a range of colleagues who are from the Department of Stomatology in Shandong. Like many of these large emerging Chinese cities, that's a very high quality institution with some serious research going on. Interesting their ethics and consent process over there, but this is an animal study and an in vitro study. And it nicely highlights the effect of hyperlipidemia on the ability of bone to osseointegrate around implant surfaces. And they've used 2 models. They've used an animal model, a mouse model, where they've placed titanium implants into the femurs of the animals. But they've also done in vitro testing, where they've looked at the growth of primary osteoblasts on titanium surfaces within an in vitro situation. And the variability is that the mice have been genetically altered to have a very high lipid content, and in the in vitro studies, they've looked at increasing lipid concentration in the culture mediums. So to cut a long story short, the bottom line is that hyperlipidemia, they have found, impairs osseointegration, both in the animal model and also in the in vitro model. Now, I find that quite interesting because I was trying to figure out, well, how can that be? And the methodology that they have looked at and investigated, usually by blocking out various pathways, and 2 main pathways they've looked at. One of them is the reactive oxidation system, or reactive oxygen species, so free radicals, if you like. And it appears that an environment of hyperlipidemia increases an overproduction of these reactive oxygen species. And of course, that's going to have a deleterious effect upon the health of the membranes and then the nuclei of any surrounding cells. And as you know, in bone formation, you're going to get a number of primary cells having to act to repair the damage that you cause by getting hold of a drill and creating an osteotomy site. The second method, slightly more scientific, slightly more complicated, is an inhibition of a differentiation pathway known as WNT or beta-catenin. It's just a name. Don't be put off by the names. They're simply names, what they identify are intracellular nuclear transcription factors that have to be activated to set osteoblasts off on their differentiation pathway. And this particular pathway appears to be affected by the hyperlipidemia, very likely, I'm sure, by the free radicals that get in. So it's quite a nice paper. It's been well constructed, beautifully illustrated, as one would expect. The Chinese pour gazillions into research, and with envy we look upon at some of the activity they have. Chinese universities are quite hard to work in because you've actually got to be very productive and produce high quality. And the Journal of Dental Research is one of those yardsticks for dental research. But I think for us that's quite interesting, because I don't know how many of you sit in front of a patient, or how many of you got pro formas that ask, do you have hyperlipidemia? And I certainly can't remember having seen it as a question on a medical history form. I don't look at them as often as you guys do, but I think in terms of Montgomery, this is something you need to consider, because if you're going to impair osseointegration, although I agree these are not clinical studies, that has to be looked at, but this is a paper from this month, 2021. So I think that's quite an interesting message to come through, and a reminder for us that we need to be asking these questions when we are taking them on as patients, because anything that impairs or inhibits the expected outcome, their expected outcome, then you need to tell them about this. And this research suggests that hyperlipidemia needs to come into that bracket. Interestingly, they go on and look at methodologies of reversing the effects of hyperlipidemia by putting in targeted pharmaceutical drugs to inhibit the inhibition, if you like. And they have shown that the quality of the bone doesn't go back to normal, becomes normal in those conditions where you've inhibited the hyperlipidemia. But the message there, I hope you can see, is that there's another medical issue you need to draw out when you ask individuals their medical histories. Have you got hyperlipidemia? The question is, do they know whether they've got hyperlipidemia? Of course. All right. Now, the second paper I would ask you to have a look at when you get the list through is actually got a bit of age on it, like myself, but like many things, age things mature well, unless you're Carl, of course, and as you can see, he's maturing very poorly. But people like myself who obviously mature very elegantly, like and Fadi. This paper comes back from 2014, and it did catch my eye. Again, got into the Journal of Dental Research, and that's no mean feat. It comes from a prolific author known as Wu, and the group of Nicolau and Tamimi, who come from a very, very well-respected university known as McGill University in Montreal. And some of you have suffered the pain of things like problem-based learning can point at McGill and say, along with McMaster's, you ruined my life. But nevertheless, they wrote a fantastic research report, clinical research report, which highlighted that individuals who've been on long-term antidepressants, SSRIs particularly, are at an increased risk of implant failure. Now, I think we need to take that into account. I recognize that antidepressants can affect platelet function. I hope everybody's aware of that. What I was less knowledgeable about is that their bone cells have got on them a range of hydroxytryptamine, which is the chemical name for serotonin, hydroxytryptamine or serotonin receptors, 1B, 2B, and 2C for the pedants amongst you. And that if you block those receptors, for example, by taking an SSRI, a serotonin-specific reuptake inhibitor, you will block an important stimulatory message to stimulate bone cells, osteoblasts, to form bone. And in fact, in the study that they've done in terms of the review of the literature, and I'll just describe the methodology briefly, it actually releases osteoclasts to have increasing function by removing the osteoblast presence and influence that it has on the osteoclasts themselves. The paper looked as a retrospective study, therefore you need to critique what's going on in there, and was conducted on notes from patients who were treated from 2007 to 2013. And they looked at two groups, those patients who weren't on SSRIs and those who were on SSRIs. And they looked at the failure rate amongst the two groups. Clearly, the non-SSRI group was much bigger, which had somewhere in the region of just over 800 users, whereas in the SSRI group, they had about 84 patients. But they looked at the failure rate in both. And the big message that comes out is that the failure rate in patients who take SSRI, who are SSRI users, there was an increased risk of dental implant failure of almost 6.3 times that of individuals not on SSRIs. So
5 minutes in, Jim.
Thank you. 6 times the risk. There's criticisms that you'll see of this paper. For example, they're obviously hunting through notes. There's no standardizations. There's no, it's a significantly retrospective. There's no issues. There's lots of notes which didn't have the doses in. And of course, the big criticism, of course, they didn't really take into account other issues like how badly depressed were they and how were they looking after their oral cavity in terms of oral health. So I looked hard to see if further cases have been looked at. Hasn't quite appeared yet. But the takeaway message is, just like the hyperlipidemia, a discussion needs to be had for individuals on SSRIs. They do anyway, because they might be on depression and their expectation issues may be changed. But there is no doubt that individuals on these medications need to have an extra discussion about risks of failure. Just quickly then, 2 other little papers that I wanted to highlight. Again, one from 2017, a critical review. I think it's quite an interesting paper because it takes into the subject of infection on implant surfaces and highlights the fact that implant surfaces, of course, are being exposed in the intraoral cavity to saliva and possibly biofilm formation, even on their journey into the osteotomy socket, but certainly into those exposed areas that have any longevity. And of course, it does bring into focus the issue of peri-implantitis. Well, the paper is written by a chap called Hitchcock, and is an individual who works, I think, in Philadelphia. Thomas Jefferson University, no mean university, can I tell you, in Philadelphia. And they've done a very nice critical review. So it's not a mini systematic, it's a critical review. So you could criticize the bias that's introduced when you do these reviews, because you go obviously for the papers that you really like to read, and that can obviously be quite subjective. But the big message was that there is definitely a potential future in antimicrobial implant surfaces. They compared 3 types. They compared the surface of implants that is unfriendly to bacteria. They looked at surfaces that release antimicrobials, and they then looked at surfaces that were permanently binding agents which created an antimicrobial surface. So they would create an amine surface onto which they would bind permanently vancomycin, gentamicin, tetracycline, a range. The bottom line is there were problems, as you will see when you read the paper, with the drawbacks that you, in terms of stability and efficacy of the antibiotics that are on there. But there's no doubt that the permanent surface alterations do seem to have an advantage in reducing the biofilm formation. Now, that's got a long way to go before it lands in the clinical arena, but keep your eyes out for that, because I think as medicinal chemistry and material chemistry increases, I think we'll be seeing more and more of these being offered in the long term. Finally, I moved away from implants. In this month's edition of the Journal of Dental Research is a very interesting paper on the oral manifestations in patients with COVID-19 19. And this is a very good systematic review by Amarim dos Santos from Brazil. It's got into the JDR, therefore it's going to be well scrutinized. Methodology of a systematic review there in terms of setting out parameters, looking at search terms, the search bases, the databases they've looked at, looking at assessment of bias, looking at fantastic statistics on how they looked at the methodology, even did a meta-analysis. So it's got a really nice review of the current status. And I thought it was interesting because it obviously makes the case for disturbance in taste. But the disturbance in taste, they broke into three areas. One was dysphagia, which of course is a sort of an uncomfortable taste rather than the normal taste. You have a sort of a painful and a disordered taste. Hypogeusia, which of course is just reduced taste. And finally, ageusia, which is no taste. And there was basically a sort of 40%, 35%, 25% split in those three areas. So when taste is affected, it has three different degrees of taste alteration. But what grabbed my eye was that there are apparently emerging evidence for other oral mucosal lesions. And they include white and red plaques. Remember, a plaque is a raised area. Irregular ulcers, blisters, particularly small blisters, petechiae, which are called a small bruising, and interestingly, desquamative gingivitis, localized in some cases. And the tongue, palate, lips, and gingivae and buccal mucosa were all affected. I think it beholds us as clinicians to keep our eyes open. To be fair, most of these conditions appeared after the onset of respiratory symptoms, particularly, but in one or two cases they did accompany asymptomatics. So I think as a clinician, we need to have that in our back pocket when we are reviewing oral cavities and any changes. And I know I must be finishing, and I will hand over now to Manoj.
Thank you, St. John.
Thanks, St. John. Right, so I have been looking at a couple of papers, and the journal I was looking at was Clinical Oral Implant Research. I've got a couple of papers which are similar. So one was a very recent paper, and one a year old. I'll begin with the more recent one. So this looked at the influence of restorative design of the crown on the progression of peri-implant bone loss. Specifically, it looked at two factors. It looked at the emergence angle of the crown, and it also looked at the prosthetic screw. It looked at the length of the prosthetic screw, and it looked at the diameter of the prosthetic screw, if that had to do, if that had any impact on progression of marginal bone loss following peri-implantitis. So we're not talking about the restorative design causing peri-implantitis. Is if peri-implantitis does happen, then does it accelerate bone loss? That's what was looking at. This is a paper by Majzoub et al. And this is from, let me see, from, hang on, let me get the paper up. From the Department of Periodontics and Oral Medicine, University of Michigan School of Dentistry. Now, coming back to the paper, it was a retrospective study. These were implants diagnosed with peri-implantitis, having a thorough follow-up. Importantly, it had follow-up 6 months prior to the diagnosis of peri-implantitis, and then they followed it up for 1 year after peri-implantitis happened, and then another year after that. Now, it's important to note the definition of peri-implantitis that they latched onto was the current one, the 2017 World Consensus Report, which, just to refresh your memory, says that if there's about 3 millimeters bone loss around an implant with a pocket depth of 6 millimeters plus, and with or without bleeding on probing and purulence, that is peri-implantitis. Now, they looked at the effect of different variables on marginal bone loss via uni and multivariate equations. And in total, they looked at 83 bone level, not tissue, bone level implants in 65 patients. The mean follow-up before periimplantitis occurred was in the range of 4 to 8 years. The inclusion that they had was quite basic. It needed to have full documentation. Patients had to be on a maintenance protocol with at least one annual clean and having no surgical intervention of the affected area. Exclusions were quite standard. Medically compromised patients were excluded, people on bisphosphonates, anti-cancer therapy, etc. Those without full records, those that didn't meet the 2017 guidelines. And if there's any surgical treatment that was done within the first 2 years for periimplantitis, those were excluded. They also excluded tissue level implants, and they excluded multiple unit implants or implants with splintered crowns. They did take information regarding bruxism, smoking, etc. But so this was not in the exclusion criteria, and they checked the influence of these variables. Now, within the included subjects, periimplantitis progression of marginal bone loss did not seem to be affected by any of the clinical characteristics, that is age, smoking, diabetes, bruxism. What did come out is that predominantly the rate of bone loss, marginal bone loss, seemed to be affected by the angle of the crown. So, in other words, if the emergence angle of the crown was more than 30 degrees, then they found there was substantially more bone loss and rapid bone loss as opposed to implants with an emergence angle which was a lot narrower. And the other factor they found, again surprisingly, that when bone loss did take place, and again this is in 66% of the implants where bone loss had taken place, that this bone level dropped to about a zone of 1 millimeter from the apical end of the internal screw. Although the internal screw length and diameter did not seem to have any impact on the marginal bone loss. Now, again, some of the things that they did not look at, I would imagine, and could have an impact, was the actual placement of the implant. How deep was it? Apicocoronally, was it crestal? Was it subcrestal? Was it supracrestal? The margin itself, was the margin a couple of millimeters away from the implant head? Was it too deep? Because if it was, then it would invade the biologic width, and that itself could cause bone loss. And this paper also referenced another paper by Yusung Yi et al. From the Department of Perio. Again, this was Seoul University. So that brings me back to the second paper, which had a bigger sample size, if you like. So as compared to this paper with a limited sample size, the next paper I'm talking about, the Yusung Yi et al., had a much bigger sample size. And this looked at something else. This looked at the emergence angle of the crown, but also looked at whether it causes periimplantitis. So the difference is, the previous paper we spoke about progression of peri-implant disease and not whether the emergence angle caused it. This paper looked at it from a different angle, slightly different angle, and it looked at whether it actually caused the peri-implant bone loss. So let me tell you a bit about this one. This was Yi et al. This was a cross-sectional study, again retrospective, but with a larger sample size, 169 patients, and they looked at 349 implants. Here, the exclusions, again, were quite straightforward. They excluded people with systemic diseases, smokers, with patients who had irregular maintenance care, and patients who had a full mouth plaque score of greater than 25%. The inclusions, they included more than what the previous paper had. They included different implant connections, so internal, external, and tissue level implants. They included history of periodontitis, bone augmentation, immediate placements, 1 or 2 stage protocols. And they also looked at various crown length ratios. Again, going back to how they designed it, inter and intra-examiner variability was assessed. Periimplantitis was diagnosed based on periimplant bone loss and bone depth. Again, like the previous paper, they used the 2017 World Workshop classification of periodontal diseases by Berglund et al. And they looked at the same similar factors. They looked at marginal bone loss, emergence angle, again, various degrees. Again, let me emphasize, the emergence angle they're talking about is the deviation. So you have your implant walls, which are parallel, and then when the crown emerges, as opposed to the wall, is it 10 degrees, 15, 20, 30, and plus. So that's the emergence angle that they looked at. They also looked at the emergence profile. In other words, was it a convex emergence profile, a concave, or a flat emergence profile? They looked at crown implant ratio and the splinting, whether it was a distal cantilever, mesial cantilever, or splinted in the middle with implants on either side. Again, the conclusions were as follows. Bone level external hex, sorry, not internal, bone level external hex had more marginal bone loss. The emergence angle, again, had a significant correlation with marginal bone loss if it was beyond 30 degrees. Again, the same thing that we saw in the previous paper. Crown to implant ratio had no significant effect at all. So basically, over-contoured and splinted implants had higher risk of periimplantitis. Convex proximal surfaces showed more marginal bone loss than flat or straight. Patients with perio history had more marginal bone loss, but not necessarily a higher rate of periimplantitis. Again, unlike the last paper, they had records from baseline, 1 year, and 5 years. So they're looking at progressively all the way up. So the conclusions here were that over-contoured implant prosthesis is a critical local co-founder for periimplantitis. The emergence angle of the crown, if it's greater or equal to 30 degrees, convex emergence profiles, and splinting to both mesial and distal adjacent implants, they found have a higher risk of periimplantitis. How am I doing, Kate, for time?
5 minutes now, Manoj.
Okay, great. So I'll go to the third one at this point. Now, this again isn't very different, but it takes a slightly different approach. We've looked at, these two papers have looked at the emergence angle of crown over contouring, and that has some sort of a correlation with marginal bone loss. You would imagine, with that in mind, that cantilevers would have a similar kind of an issue. So the third paper was a paper I looked at. This was by Eric Schmidt, Giovanni Salvi, Anton Scully. This is the Department of Periodontology, University of Bern, Switzerland. And this looked at clinical and radiographic outcomes of implant-supported fixed dental prosthesis, in other words, cantilever extensions. A retrospective cohort study with a follow-up of at least 10 years. So a long follow-up. It looked at patients with cantilevers in posterior areas only, so the canine back. They were evaluated clinically and radiographically. They looked at the marginal bone levels from baseline all the way up, and these were compared between different implant surfaces adjacent to and distant from the cantilever extension. In total, they looked at, it was a smallish sample size, I would imagine, but a long follow-up. They looked at 26 patients with 30 cantilever extensions, supported by 60 implants. So if you calculate, you had typically at least a couple of implants supporting a third pontic, a pontic. The patient selection was quite strict. They were looking at patients. The inclusion criteria was patients with good systemic health and uncontrolled medical conditions, patients with healthy or treated periodontal conditions, and patients who were in regular supportive periodontal therapy. At least 2 implants supporting a third, but they were looking at basically Straumann tissue level implants, which had an extra abutment attached to them. And the attachments normally they looked at was a single premolar or a single molar unit with an extension of not more than 6 to 7 millimeters. Now, again, in the inclusion criteria, there had to be an absence of occlusive contacts or guidance on the extension. So this was the basic inclusion. Exclusion criteria were limited. Untreated or active periodontal diseases was a main exclusion criteria, and they excluded implants in the anterior zone, in the aesthetic zone. Now, results: marginal bone loss and pocket depths. Both they found were surprisingly quite limited. They found a little bit of an increased marginal bone loss and an increased bone to implant contact loss immediately adjacent to the pontic and at the part of the bone furthest away from the pontic. A slight increase in pocket depth closer to where the pontic was, but not statistically significant. So on an average, long-term pocket depths change by about 0.4 to 0.5 millimeters, and marginal bone loss did not increase by more than 0.2 or 0.3 millimeters. So quite limited for procedures going on for 10 plus years. Ultimately, conclusions were these. Although peri-implant health was diagnosed in 46% of the implants, peri-implant mucositis in 26%, and limited peri-implantitis in 7 patients in total. That is 26%. What they did find was a higher rate of loss of retention, in other words, prosthetic complications. Those were higher. And as far as success or survival goes, only 1 implant was lost. When we say lost, 1 implant, a narrow diameter one, was fractured. So their conclusion was that despite a high rate of loss of retention, the use of implant-supported fixed bridges, cantilevered bridges, was a reliable long-term option. I think I've run out of time. Is that right, Kate?
Yes, you're just there, Manoj. You're just there. Yes, that's fantastic. Carl, Fadi, Manoj, Sinjan, thank you very much. Over to you, Fadi.
Thank you everybody for that. I hope you guys who are watching found this useful. There was one theme I've noticed in one of my papers that I was talking about with cardiovascular risk factors. The triglycerides was one of them, and just the relation with one of the papers you were mentioning that hyperlipidemia was an issue, and that's actually interesting that there were 2 papers we found that are actually relating to that. The other stuff with Carl and Manoj, the stuff he came up, which was again reinforcing, I hope you both agree, a lot of stuff we teach on the course. A lot of what you found in these recent papers is still is encouraging that that those thoughts haven't changed really. Any comments from anybody before we close?
I'm only 21, actually, Sinjan. So you're quite right. I've aged awfully.
You need to wear more makeup.
You get rid of that shiny part. I love that, you guys. Thank you very much. I really enjoyed it. It was some lovely stuff there. I'm gonna have to. Just to let everybody know, we didn't know what each person picked from these papers. So maybe we do need to know so we don't duplicate things, because we do read from different articles. But that was superb. I really enjoyed that. Thank you all very, very much, and thank you guys that are listening.
I want to say a special thank you to Professor St. John Crean, actually, as our guest panelist today. Sorry, Manoj, you were going to say something.
No, I'm seconding that, really. About the makeup, that is.
It's going to be a lot of makeup, mind.
Yeah, goes into my. Well, no, we won't go there.
Won't go there at all. I just want to echo what the guys have just said. Thank you to everybody for tuning in, and we will look forward to seeing you again, we hope. Hope you all have a lovely weekend, and the panelists again, please, Carl, Fadi, Manoj, St. John, thank you very, very much.
Kate, thank you. Can I just say the papers will be available for those that are free access. We'll get those, the PDFs, and for those that aren't free access, we'll give you the titles, the authors, and where you can find them, just so that everybody gets a look at the papers that they might be interested in reading further, which I recommend by the sounds of it, all of them.
Yeah.
And thank you very much. Thank you, Kate.
Is the next one, is it the 4th Thursday of the month? Is that right? Or
it's what we're going to confirm, but that's what we're trying to do, yeah.
Yeah.
Right. Thank you.
Fantastic.
Thank you very much.
Have a good weekend,
Good night, everybody.
everybody.
Yeah. Take care, everybody.
Bye-bye.
Bye.